Assalamu alaikum. Our topic today is prostate cancer. Prostate cancer is the most common cancer in men other than skin cancer. Many men live and die with prostate cancer, but not from prostate cancer. You can see in this slide, more than 75% of men died by age of 85 were found to have microscopic disease on autopsy. But still, prostate cancer is the second leading cause of cancer death in men after lung cancer. Its incidence has been increasing, but for an unknown reason. Most believe it is because of the increasing use of PSA screening tests. Now, we do believe prostate cancer is a disease of aging process. Comorbidities cause death in men who coincidentally diagnosed with indolent slow-growing prostate cancer. Identifying those men with screening may unnecessarily subject them to cancer, anxiety, and cancer therapy with its complications. This leads us to the dilemma of overdiagnosis, overtreatment, and of course, misdiagnosis if we don't do screening tests for our patients. The question is whether a man died from prostate cancer or with prostate cancer. This depends on how aggressive is the cancer, how early the cancer was detected, how effectively the cancer was treated, is any comorbidities, and the age of the patient. The dilemma of overdiagnosis. So let us compare the ratio of new diagnosis to disease-related mortality between two types of cancers. Look into this slide. Prostate cancer, the ratio of new diagnosis to disease-related mortality is 8.6 to 1. On the other hand, for lung cancer, the ratio is 1.4 to 1. That means many patients with prostate cancer, they don't die from the cancer. And you can see the opposite in case of lung cancer. This slide displays the risk factor for prostate cancer. Age, as we said, elderly more likely to have prostate cancer even on autopsy when they die from other causes. Ethnicity, Africans more likely to have prostate cancer compared to Caucasians. Family history of prostate cancer, or even family history of some genetic mutations such as BRCA and ATM. Certain diets may increase the risk of prostate cancer: animal fat, red meat, and low vegetable. Presentation. Most of prostate cancer is asymptomatic, only discovered by screening PSA, and some by digital rectal exam. Some present with urinary symptoms. Very small number of patients present with metastatic disease, especially to bones, having bone pain, and some present with fatigue. Now, we're going to the dilemma of the screening. Overdiagnosis, misdiagnosis, overtreatment are all related to this screening test, PSA. The rationale for screening men for prostate cancer is the potential to reduce the risk of death through early detection. Overdiagnosis. The story of overdiagnosis goes back to the 1980s when American men have been offered an alternative to digital rectal exam, DRE. Of course, PSA is more sensitive and specific. That led to diagnosing more people with prostate cancer, which we call nowadays overdiagnosis of prostate cancer. Of course, that has led to overtreatment of low-risk patients. Now, we need to draw a distinction between overdiagnosis and misdiagnosis because while there are many patients diagnosed with low-risk disease, there are some may end up having a life-threatening disease, very aggressive disease. So we need to figure out what to do. PSA, prostate-specific antigen. It is now recognized as a screening blood test for prostate cancer. The cutoff of PSA for biopsy to diagnose prostate cancer is 4 nanogram per ml. Anything of 4 or more nanogram per ml is concerning for cancer with sensitivity of 21% and 91% specificity. False positive for PSA usually in the range of 4 to 10. And that is typically with a normal digital rectal exam. That means 1 out of 3 patients still could have cancer in this range. False negative. 1 out of 7 patients may have cancer even if the PSA is less than 4. PSA is not only elevated in prostate cancer. It could be elevated in BPH, benign prostate hypertrophy, or perineal trauma, or prostatic inflammation or infection. To improve the PSA result, a couple of tests has been added to the PSA. PSA density, which is the ratio of PSA to the prostate volume. Anything less than 0.15 nanogram per ml per cc of the volume of the prostate is considered favorable. Ratio of free to total PSA also is very helpful. A ratio of less than 10 to 15, highly suspicious for cancer. So low ratio is suspicious, high ratio is less likely and is probably due to PPH. PSA velocity, which is a change of the PSA over time. Typically, a velocity of 0.75 or more per year is suspicious for malignancy. It is not helpful for a PSA of more than 10. So we go back again to the dilemma of overdiagnosis versus misdiagnosis. Increasing detection of early prostate cancer will increase, of course, detection of both non-aggressive and aggressive disease. That's the fact. So the challenge is identifying cancer biology, try to help us to identify who to treat to decrease morbidity or mortality. So far, there is no screening test is available to differentiate between aggressive versus non-aggressive prostate cancer. So, we need to balance between small benefit of the screening, which is reducing mortality, reduce the risk of developing metastases, balance that with the potential harm from the screening PSA test, which is a false positive PSA, which brings, of course, anxiety, overdiagnosis, which will lead to overtreatment, and the complication from the treatment itself, or even the complication from the biopsy before even the treatment. So those things has to be balanced very carefully. Here are the guidelines for the screening. First of all, before we start the screening, before we start the test, we need to counsel those patients. Average risk patient, patients without high risk. We should discuss with those patients the risk and benefit starting with age 45, maybe 50. For high risk patients, Black, patients with family history of prostate cancer or family history of genetic mutation, BRCA, those patients we should discuss with them the risk and benefit a little bit earlier at age of 40. Also, we should make sure those patients, average risk or high risk patients, should make sure they understand the pros and cons of the screening very well before even we offer them the biopsy. Pros and cons of prostate cancer. Here are some pros and cons. Men having regular PSA tests, of course, they are at higher chance of finding out have cancer. That means anxiety, and that means may end up receiving unnecessary treatment. On the other hand, men having no PSA test, of course, lower chance of finding out have cancer, but at the same time, higher probability of having advanced disease at time of diagnosis. Cancer versus treatment. Cancer, of course, means morbidity, mortality, or maybe none. Treatment is all about quality of life. Treatment brings fatigue, hot flashes, urinary symptoms, bowel symptoms from radiation, for example, and erectile dysfunction. What are the harms from a simple blood test for a PSA? There are harms because a PSA, as we said before, it could be a false positive test. And if it is an elevated PSA, the patient may end up with biopsy, and that could cause some complications, including hematuria, infection, sepsis, hematospermia. Or if the biopsy shows a true diagnosis of cancer, that may lead to treatment, and the treatment has its own side effects. For example, androgen deprivation therapy, ADT, related symptoms, such as hot flashes and fatigue, urinary symptoms, erectile dysfunction from the local therapy, surgery, or radiation. Overdiagnosis, of course, as we said before, diagnosing a disease that would never be diagnosed without screening, and of course, overdiagnosis could lead to over-treatment. Dilemma of screening. Obviously, there is some uncertainty of screening benefits. Question: what is the gain for a man at age of 75 or older? And what is the gain for a younger man with comorbidities? Another issue is the harm from screening, which may lead to overdiagnosis and overtreatment with its complications. But remember, on the other hand, no doubt there is a significant decrease of the rate of metastatic disease at time of diagnosis. 70 to 80% are now organ-confined prostate cancer at time of diagnosis, which means the patient could avoid dealing with metastatic life-threatening disease. In summary, PSA testing is likely optimal for early detection in high-risk populations instead of general population. The question is how to identify those high-risk patients. Unfortunately, screening trials did not address high-risk factors. Prostate cancer early detection guidelines are continuously in a state of evolution. Now, let us move away from the area of uncertainty and confusion to the practical zone. Now, you may see a man for the first time in your clinic. You need to do some kind of risk assessment and stratification. Of course, you start with a good history and physical. Family history is very important, especially family history of prostate cancer. Genetic testing, if it has been done, especially for BRCA. History of prostate disease and prior biopsy for whatever reason. Ethnicity, life expectancy, medications, 5-alpha reductase inhibitors, which lower prostate specific antigen PSA by 50%. Those patients, when they develop disease, they may develop a high-grade prostate cancer. You need a baseline digital rectal exam and a PSA for your screening. Your patient is going to be one of the three groups. First group, high-risk patient, and those are African ancestry patients, patients with BRCA or ATM mutation or deficient MMR. Patient with family history of prostate cancer. This is the high-risk group, and you start doing screening for this group at age of 40 until age of 75. Average risk group, everyone else until age of 75. For this group, you start the screening at age of 45. The third group, elderly, age of 75 or more, healthy 75s. Of course, you do not start screening for any patient until you counsel the patient and share with the patient the risk and benefit of the screening and the biopsy, of course. So after full explanation, make sure they understand the pros and cons of the screening and the biopsy. Now, for the high risk and average risk, you do a PSA and a baseline digital rectal exam. If the PSA is less than 1 and the GRE is normal, then you repeat the PSA every 2 to 4 years until the age of 75. If the PSA is 1 to 3 and the GRE is normal, then you do PSA every 1 to 2 years until age of 75. If the PSA is more than 3 and or the digital rectal exam is abnormal, prostate is hard, there is a prostatic nodule, of course you rule out benign disease, and for those patients you recommend biopsy. Transrectal ultrasound guided biopsy. For this group of patients, may consider doing MRI of the prostate and or biomarkers, urine or serum biomarkers, especially if the patient prefer to wait and not to rush into the biopsy. So the MRI or the biomarkers may help in this situation. Or of course, you may follow the patient in 6 to 12 months for a repeat PSA and rectal exam for the prostate. The third group, elderly patient, 75, more than 75-year-old, healthy ones. For those, if the PSA is less than 4 and the digital rectal exam is normal, you may repeat PSA in 1 to 4 every 1 to 4 years. If the PSA is 4 or more, of course you rule out benign disease. If the patient is healthy with life expectancy more than 5, especially more than 10, then you recommend biopsy also. And consider MRI and or biomarkers, urine or serum biomarkers, to help with the decision for the biopsy. Or of course, you can follow the patient in 6 to 12 months with a repeat PSA and a DRE. These are the guidelines for the screening and the biopsy. Once you and your patient decided for the biopsy, you need to take into account the PSA density, PSA velocity, and the PSA free and total PSA results, in addition to the PSA value itself. Also take into account comorbidities, if any prior biopsy, and you may need to do an MRI of the prostate as well as biomarkers. Here are some of the biomarkers that could help on deciding biopsy, or at least postpone it for later on. Some of the biomarkers could be done in blood, like the 4K score, prostate health index. Some of them are urine test. Here are the tissue biopsy biomarkers. So of course these are not to decide on the biopsy. These are done on the biopsy to help on treatment, like active surveillance versus surgery versus radiation, wait and see, those kind of things. So these are tissue biomarkers. Now, we did the biopsy and we need to review the pathology. 95% of prostate cancer are adenocarcinomas, and the common adenocarcinoma is acinar carcinoma. here are the other type of pathology, like the neuroendocrine, urothelial carcinoma, basal cell carcinoma, lymphoma, carcinosarcoma, or sarcoma. Very rare. You may have heard of the Gleason score or the Gleason grading system. Basically, the Gleason score is telling us about how differentiated the cancer. Is it a well differentiated, moderately differentiated, or poorly differentiated? A score of 6 or less, that is well differentiated. A score of 9 or 10, poorly differentiated, bad. Of course, 7 is something in the middle. So that is the Gleason score. And now we use the grade group, which is made from the Gleason score. So the Gleason score depends on the pattern of the differentiation of the cancer. And the Gleason score is very well correlated with the recurrence and the free survival for the patient. And it is used and incorporated into the staging system when we see later. Okay, the TNM prognostic staging system, now it includes the tumor itself, of course, the size of the tumor, the depth of the tumor in the prostate, the sites and the core biopsy involvement. That's the T, and then we use the PSA as well as the Gleason score or the grade to make the staging. That's for local local or regional disease. Of course, any disease in a lymph node or distant metastasis, that is advanced prostate cancer. Management. The management of prostate cancer depends on the risk factors and stratification of the disease. I like to use the stratification according to the NCCN, National Comprehensive Cancer Network. Treatment of localized prostate cancer reduced mortality compared with observation alone. This came from multiple studies. One of them is an Scandinavian randomized controlled trial with 15 years follow-up, and that showed radical prostatectomy decrease prostate cancer specific mortality by 38% and reduce all-cause mortality by 25%. Other studies of surgery and radiation therapy validate that result with 35% reduction in mortality. Once the disease is confirmed and the decision is made to go ahead with treatment, typically we do some kind of initial evaluation. For local disease, we do MRI of the pelvis or the prostate. The MRI is done for low-risk patient to decide on surveillance versus immediate treatment. On the other hand, for high-risk patients, we do MRI for staging to decide between low-risk early disease versus high-risk and locally advanced disease. Also, we need to do a CT scan of the abdomen and pelvis, and that's typically done for intermediate, high, or very high-risk patients. Bone scan for symptomatic disease or intermediate, high, or very high-risk disease. PET scan PET scan, of course, is done for advanced disease, and the sodium fluoride PET scan is better than the regular PET scan. Evaluate the patient for hereditary cancer by doing germline genetic testing, the BRCA, specifically for patients with family history of prostate cancer or even history of other cancers, breast, ovarian, pancreatic, and GI malignancy, patients with cribriform or intraductal prostate cancer. They also add risk for hereditary prostate cancer. Biomarkers, tissue biomarkers done on the biopsy. Very helpful, especially when if the patient is considering active surveillance versus immediate therapy. Those patients usually with a life expectancy more than 10 years. These are the treatment options: radical prostatectomy, radiation therapy, either external beam radiation or brachytherapy, ADT, androgen deprivation therapy, or castration. This could be achieved surgically by orchiectomy or medically by hormonal therapy, LHRH agonist or antagonist, and anti-androgens, chemotherapy for metastatic disease, and now immunotherapy is an option. So who to treat? Again, risk category stratification. We need to select patients who are at some risk, intermediate risk, high risk, or very high risk. We'll talk about those later. Life expectancy should be more than 10 years, patient with no significant comorbidities, and of course, patients with symptoms. Treatment option, one of the treatment option is androgen deprivation therapy, ADT. Testicles produce 90 to 95% of the testosterone. 5 to 10% comes from the adrenal glands. Testosterone is converted into dihydrotestosterone, DHT, by enzyme 5-alpha reductase. DHT, or dihydrotestosterone, lead to growth of both benign and malignant prostate tissues. That's why hormonal therapy, either medical castration or surgical castration, is a treatment for the prostate cancer. Again, ADT, or the castration, is done surgically by orchiectomy or medically by the gonadotropin releasing hormone analog injections like Lupron or Zalodex. Remember to take precaution if a patient has vertebral metastasis, because gonadotropin releasing hormone analog, they first increase the production of the testosterone, and that could cause a flare and swelling of the metastatic areas before it shrink it. So that's why we do use anti-androgen first before the LHRH agonist. But now there is a gonadotropin releasing hormone antagonist, Pharmagon. That's an injection, and there is an oral form too. For those, the antagonist, there is no need for the anti-androgen before the treatment because there is no surge. There is no surge of the testosterone. Another type of hormonal therapy is an anti-androgens. Biclotamide, and now there's a lot of them listed in, I mean, like 5 options of oral anti-androgens. Estrogen is an old form of treatment. It's not, I don't see that used nowadays. I mean the estrogens. So now let's just talk about treatment based on the risk and stratification of the disease. Clinically localized or very low risk disease. Those are patients diagnosed on biopsy based on PSA. They have no symptoms. Yes, the PSA is elevated, PSA of 5, PSA of 6, and now they have a biopsy, core biopsy, and diagnosed with low grade. Remember the Gleason score 6 or less, and that's a group 1. And the PSA typically less than 10. So those patients with the life expectancy more than 10 years, we can just keep an eye on them. Active surveillance. They may not need treatment. Yes, they need surveillance. The second group is clinically localized low risk. Remember that was a very low risk. This is a little bit higher stage, a little bit, T2 up to T2A, and the PSA is still less than 10, and the Gleason score is less, is still 6 or less, and but they don't qualify for the very low risk. So we treat them with either radical prostatectomy, radiation therapy, or even active surveillance. Of course, they should have life expectancy more than 10 years. And again, uh, biomarkers for those patients is very helpful, actually. This is a group that is they benefit from the biomarker a lot. Oncotype DX can do that and give you some idea about treat or observe. The third group is clinically localized intermediate risk. So a little bit higher than the previous, but it still has, this group has favorable outcome. The PSA, if you see, is in the range of 10 to 20. And the Gleason score is a little bit higher. Gleason score of 7, and the grade is 1 to 2, grade group is 1 to 2. All these patients, they have life expectancy more than 10 years to treat them. Again, this group also benefit to some extent from the biomarkers. This treatment is, if you see, we move a little bit from active surveillance to radical prostatectomy or radiation therapy with or without ADT, androgen deprivation therapy. Now we move a little bit higher for clinically localized intermediate risk. If you see here, the tumor is T2, T2C, and the group is higher, so it is more than the previous groups, a little bit more aggressive disease. And so those patients, if they have family history of prostate cancer, or the cancer has a component of cribriform in the specimen, the pathology, those patients, we should do, if you remember, we said family history of cribriform, we should do germline testing, the BRCA. And the treatment, there is no active surveillance for this group, if you can see that. It either remove the prostate, radical prostatectomy, or radiation therapy with or without ADT. We go a little bit deeper. Now, clinically localized high risk. If you can see that, that's a T3 or a Gleason score of 8. Remember, we said 8 or 9 or 10, that's the highest, but this is an 8, getting higher and higher. So the Gleason score is actually or glycemic score of 9, PSA more than 20, so high risk. So those patients, of course, there is no active surveillance for those. We recommend for them treatment. And also we do germline testing on those patients, the BRCA testing, and we treat them. Usually the treatment for this group is radiation therapy, external beam radiation therapy, with or without brachytherapy, with in addition to androgen deprivation therapy for up to 3 years. Is given like an hormonal injection uh, every month, or maybe every 3 months, maybe every 4 months, or even maybe every 6 months. It's a long-acting hormonal therapy. Or we can do just ADT if they are not candidate for local definitive therapy or their life expectancy is limited. Asymptomatic elderly patients with life expectancy less than 5 years or less, we may just consider observation for them. And now we go even higher, locally advanced, very high risk. They're not metastatic yet, but they're heading there. These are the Gleason score pattern of 5, and so they have more aggressive disease. Those patients, we should actually make sure they do not have metastases. So we do CT scan to make sure they don't have metastases, MRI pelvis. You remember we said we do MRI for this patient to make sure there is no locally extensive disease in the pelvis. And of course, we do germline testing, the BRCA test. Treatment again, radiation therapy with or without brachytherapy, plus ADT for up to 3 years. Even we may give them chemotherapy because those patients, we know they are at high risk and their disease may come back after the initial treatment. Again, life expectancy less than 5 years, asymptomatic. You may consider observation. Okay, so this is the treatment of a disease that is not metastatic. You may see a scenario of cancer come back based on PSA. Patients feel fine because all prostate cancer are monitored with PSA. If the PSA become detectable after radical prostatectomy, or PSA starts creeping up, that is a biochemical relapse. So biochemical relapse, if the patient not on hormonal therapy, we consider their disease is castration sensitive, hormonal sensitive. So for those patients who relapse after radical prostatectomy, they relapse after surgery. Those patients, we treat them, if we treat them with salvage local therapy, like radiation, they're unlikely to benefit from that and unlikely to achieve durable control of their disease. So we recommend to treat them with ADT. PSA starts creeping up after radical prostatectomy. That means this PSA is coming from somewhere. The prostate is already removed. So they have quote unquote micrometastases. So deprive them from testosterone with ADT. However, the optimal timing is controversial, but we do believe early intervention is better than the wait and see, especially if they're young patient, and especially if the doubling time of the PSA is less than 10 months. PSA of 4 in 7 months or less than 8 months, anything less than 10 months. If the PSA was become 4, 2 become 4, or 4 become 8 or 9. So the doubling time less than 10 months means risk of metastasis is higher. What about a biochemical relapse is still castration sensitive? That means they are not on therapy and they did not have orchiectomy. So they are still could benefit from hormonal manipulation. So if this happened following radiation therapy as the primary treatment, if that happened, we recommend to do biopsy because remember, they still have the prostate and the PSA could be coming from the benign prostate, not from the cancer. So we don't jump immediately to treatment. So we do recommend biopsy if possible. If the biopsy is positive, showing cancer, then salvage treatment with radical prostatectomy is the way to go. Or even may consider cryotherapy or brachytherapy. If the PSA is still rising, then we do add ADT because we know after salvage therapy, this PSA is coming from somewhere, even if we could not detect it. Of course, we do scans trying to find the source of the PSA. Remember the sodium fluoride PET scan or either regular CT scan or a bone scan could identify the source of the PSA. Following definitive radiation therapy, or if the patient not candidate for salvage therapy, we just go immediately to the hormonal manipulation with androgen deprivation therapy. Remember, we do the biopsy because I think I already mentioned that because the PSA could be due to the normal prostate tissue, the pH. In that case, you could do a trial of the medication typically used for BPH, the 5-alpha reductase inhibitors, or you can just monitor them for a few months before you you subject them and commit them to long-term treatment with ADT or orchiectomy. What if the PSA started rising while the patient already on hormonal therapy? Remember, we said sometimes we do give the ADT treatment for up to 3 months for the high risk disease. So if the PSA continue to rise on top of that, well, if the PSA doubling time is less than 10 months, we do add an anti-androgen, and all these are pills. Zytiga, Xtandi, those are the enzalutamide, which is Xtandi. Those are anti-androgen. Remember, the up to 10% of testosterone come from the adrenal gland will be taken care of by by the anti-androgen. So you do add an anti-androgen. Of course, you continue the LHRH, Lupron or Zalodex, the injections. You should not stop them because the PSA continue to rise. If the PSA doubling more than happen later on, more than 10 months, a year or more, well, you could observe those patients because they could have just a slow growing disease, and instead of subject them to anti-androgen and side effects of that, you could just keep an eye on them. Or you may add anti-androgen. So, and here are the options. Okay, now, disease has metastasized. It's not only a rising PSA. A rising PSA, in addition to radiographic metastasis. Bone scan is positive for metastasis. CT scan shows metastasis, lymph nodes, bones, liver, lung, usually either lymph nodes or bone. Visceral metastasis is not very common for in prostate cancer, but it could happen. So, metastatic disease. First line treatment. Remember, before we look into treatment options, remember, all metastatic prostate cancer nowadays should be tested for germline mutation. So germline testing is the must. Why? Because if we find the patient has germline mutation like BRCA or ATM or any of these listed mutation, those patients could benefit from oral non-chemotherapy treatment, PARP inhibitor. You remember Lymbalza or olaparib? This is an oral non-chemotherapy. This is targeted therapy. They target those genes. This, of course, the germline mutation is a blood test. So if the specimen is available, we can do the test on the tissue with the next generation sequencing, NGS, for somatic mutation for the same genes, which we call it HRR. The BRCA ATM, CHEK2, we can find those in tissue, and if they have that, still they could benefit from non-chemotherapy targeted medicine like Lymbalza or olaparib. Remember, lymph node involvement in prostate cancer is considered metastatic disease. It's stage 4A. The treatment for those, if the lymph nodes confined to the pelvis, even if they're stage 4, we could treat them with definitive radiation plus ADT, androgen deprivation therapy. If they're young, healthy, with limited lymph nodes, even in stage 4, we could treat them with surgery, radical prostatectomy, and then follow that with adjuvant uh, radiation, with adjuvant hormonal therapy, with or without radiation. But if they have disseminated disease outside the pelvis, that's stage 4A, the treatment is systemic, which is androgen deprivation therapy. You remember, all the time, even if we use chemotherapy or targeted therapy, all the time, androgen deprivation therapy, hormonal therapy should be on board, should be used. Even if the disease come back, we never stop the hormonal treatment. So we do ADT with or without chemotherapy. We use chemotherapy for visceral metastasis and young patient with good performance status. High-grade, low PSA prostate cancer. This is a very rare type of prostate cancer, which is a small cell or large cell neuroendocrine carcinoma. This type of cancer does not produce PSA. So it is not the adenocarcinoma type. So this is a very aggressive disease, and it could be life-threatening in a short period of time. If it's localized, we treat them very similar to the high-risk or very high-risk prostate cancer. And if metastatic, we treat this type of cancer similar to small cell lung cancer, the very fast-growing lung cancer, using platinum and etoposide. Again, disseminated castration sensitive, that means patient not on hormonal therapy, they develop mets. The immediate rather than delayed ADT is better, especially for high risk prostate cancer. And those we give them the ADT plus anti-androgen or chemotherapy. On the other hand, for low burden bone metastasis, very limited bone metastasis, treat the prostate with radiation therapy plus ADT. Castration-resistant prostate cancer.
If metastasis discovered while the patient on hormonal therapy, the hormonal injections, the LH agonist or antagonist, do not stop those. You continue the hormonal therapy, but add to it. Sometimes ADT is given with anti-androgens. If that's the case, you may try hormonal withdrawal by stopping the anti-androgen. Do not stop the injections or the ADT. Do not stop that. You continue it. Of course, if the patient has orchiectomy, that's permanent. But if they have an anti-androgen in addition to the ADT, you may try hormonal withdrawal because it could help. This phenomenon has been uh, observed and has been tried, and it could help sometime. But anyway, if the patient is on ADT, do not stop it, but add to it. You can add to that one of the 7 options listed here. Of course, if they have deficient MMR or MSI high, give them immune therapy, PD1 inhibitor like Keytruda or Bembro. If they have BRCA mutation, give them PARP inhibitor. The other options are anti-androgen or chemotherapy docetaxel or even radiation, the radium or Provench. These are just options in addition to the ADT. For patients with bone metastases, we give them biphosphonate or denosumab to stabilize bones, basically repair bones. Is given with calcium to stabilize bones and prevent fractures and bone events.
At the end of this session, I have 3 take-home messages. Message number 1, prostate cancer is considered an aging process. Many patients may live and die with this disease, but not from it. However, others may suffer and die from it at younger age. PSA saves life, but at the same time may subject some to an unnecessary procedures and treatment due to the overdiagnosis. Before ordering PSA for screening, please make sure you share and discuss with your patient the risk and benefit and the pros and cons of this test, and of course its consequences. Take home message number 2. It is about treatment. Hormonal manipulation, ADT, androgen deprivation therapy, is the backbone for treatment of advanced prostate adenocarcinoma. So, it should not be discontinued in case of progression while on hormonal therapy. Actually, it should be kept in addition to other therapeutic options for castration-resistant prostate cancer, such as chemotherapy or immune therapy. Remember, all patients with metastatic prostate cancer should be counseled and tested for germline mutation, BRCA, ATM, and others, with or without somatic homologous recombination repair, HRRG mutations. This is for 2 reasons. Reason number 1, to identify families with hereditary cancer. Second, because those patients may benefit from non-chemotherapy medications such as PARP inhibitor, olaparib, or Lynparza. Final message: screening programs, diagnostic and therapeutic medicine is evolving continuously. And of course, management of prostate cancer is not an exception. So please keep yourself current and up to date to identify those patients at high risk so you could screen them timely and treat them properly. And thank you much.